हेलो। 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 हेलो।
Hello. Hello.
हेलो,
Hello.
कैन यू हियर मी सर?
Am I audible to you?
यस
Yes,
सर।
sir.
Okay.
Audible, sir.
Okay. So there was some confusion between. Okay.
सर
Yeah, you can open the room. In 2 minutes, we'll start. Okay. Okay. Asmita, shall I start? Shall I start? Okay. Okay. So, good evening to all of you. Now, last discussion, I talked about, somebody asked about some condition. I told that I will be showing that video of that patient. I will show the video, share the video first. Video one condition, which was discussed last time. Okay, is my screen seen?
Yes, sir.
यस सर।
Now, this case is actually given to me by Dr. Madhuri from Osmania Medical College. This case was shown to you earlier about 1.5 years back. This case came under discussion last week. That is why I thought I will show this case to this week. Now, this is a story of a 16-month-old baby. She was brought by her mother for complaints of deformity of both upper limbs since birth. Mother did not give any other complaints. This is a video of the child. Look carefully at the face.
Sare bye jappu bye jappu. Bye go bye.
At the face of the child.
Bye.
She was given a pen. Now she holds the child holds the pen and we can see.
పట్టుకోవాలి పట్టుకో 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 వదులు వదులు ఇచ్చే నాది ఇచ్చే కూర్చో
Whole trunk is like a log of wood.
కూర్చో
Not able to bend or stay straightened.
కూర్చో 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 కూర్చో
With the arms just flexed, the elbow
కూర్చుంటా లేదా
erected,
సరే
flexed.
సరే బాయ్ మ్యామ్ బాయ్ బాయ్ మ్యామ్ ఫోటో పైకెత్తు అట్లా కాదు ఇట్లా చేతులతో పట్టి లేపు
There is stiffness or irritation.
అలాగా అయిపోయింది
Due to the abdominal wall is also rigid. So what do you think the patient is having? Any thoughts?
Schwartz-Jampel syndrome.
Yeah, exactly. Schwartz-Jampel. Somebody asked about last time. So look at the face of the child. There's classical, this epicanthal fold, pinched up lips, long philtrum, and receding chin. And this facies is very typical and classical of this condition. So it becomes a spot. This on the old from the literature, the face on the right side. This is another child which I had seen much earlier while I was immediately after my DM. I did not know what this condition was. Look at the child. Also rigid like that. The arms are also just like then I can rotate the whole child by
any particular passive in the movie and any casting.
I can hold it through.
Limp the movie, can full range button.
And look at the abdomen also very rigid, just like the previous side.
I must have that.
The abdomen stiff. So this is a child photograph. So look at the child's similarity with the one in the literature. Almost the same faces and this thing. So at that time, I did not know what this condition was. Now I know this is a Schwartz-Jampel syndrome. At that time, we didn't have an EMG machine to confirm it. This is again from the literature. So this is EMG of the patient. Classical myotonia. In between there is CRD also. There's a CRD. In between there's a myotonia. So persistent motor activity at rest, myotonic discharges, and CRD. So this is Schwartz-Jampel syndrome. 2-3 words about this condition. This is inherited as autosomal dominant and autosomal recessive. Most patients become symptomatic between 3 years and 10 years. They present typical phenotypic features characterized by short stature, mask-like facies, epicanthic fold, receding chin, upturned nose, long philtrum, short neck, pinched up face, that is very characteristic, low set ears, and prominent muscles and high-pitched voice, just like see the Kai of the child. The diagnostic findings are typical facial appearance, muscle hypertrophy, and continuous muscle fiber activity. They have slow movements with arms semi-flexed, just like look at the child. Toe walking, difficulty in opening the mouth, mild kyphosis, mild contractions of the elbow and spine, metaphyseal deformities, lumbar lordosis, limited movement in major joints. So that is this is again from the literature, the previous from the showing the similar condition. Okay, so that's it. So this is only to reiterate, show the case which was promised to show last time. So any questions in this case before I go to the proper case?
Sir, other than the facies, is there any way to differentiate it from stiff baby syndrome, stiff person syndrome?
In fact, the stiff baby and stiff person syndrome, in fact, if you look at the literature, if you type what is stiff baby syndrome, the condition comes as hyperplexia syndrome. That is what they have got. I do not know why they came, because this stiff, I thought this stiff baby. Why baby is stiff? That's all. But when I looked at literature, there is no description of the so-called stiff baby's condition at all. Whatever condition they have mentioned is only hyperplexia syndrome. Nothing to do with the stiffness. I do not know why they coined that particular term. The stiff person syndrome is mimicking that also stiffness of the marked contraction of the paraspinal muscles and the limb muscles starting in the paraspinal muscles. That is almost similar to that, but the problem is entirely different. One is localization in the anterior console, the other is localization in the muscle membrane. That is a myotonia is responsible here. Whereas in stiff person syndrome is the disinhibition of the anterior horn cell producing excessive motor unit activity. So if you do the EMG is typical of excessive muscle contraction, just like you contract your muscles in stiff person syndrome. But here it is a myotonic discharge. So examination-wise, you find both the conditions muscles will appear stiff. In stiff person syndrome, in addition, you will find episodic myoclonic jerk or spasms will come in between. But in myotonia chondral dystrophy, that spasm will not occur. Third thing is in stiff person, there is stimulus sensitive. You get stimulus, the spasms will come because basically it's a disinhibition of the anterior horn cells. So that's the three differentiating features between a stiff person syndrome and the so-called chondrodystrophy, myotonia or myotonic disorders.
Thank you, sir.
Thank you. Okay.
How to differentiate it from myotonic dystrophy?
Myoclonic dystonia is the myoclonic dystonia is only episodic, only action precipitated, and it's myoclonal. Here there is no myoclonus.
Myotonic dystrophy, I mean.
Oh, myotonic congenital myoclonic dystrophy. So that has got they have got features of myotonia, and they have got other characteristic facial features of fish mouth and all, and there's characteristic distribution. In fact, chondrodystrophy myotonia is a myotonic disorder simulating any other myotonic disorder. The only thing is that this chondrodystrophy myotonia got classical facial appearance, classical distribution of the myotonic discharge, especially the puckering of the face, blepharophimosis. But it is different from what you find in a congenital myotonia or myotonic dystrophy occurring in congenital in the early age group. Or neonatal myotonic dystrophy, little different because the distribution of involvement is different. Otherwise, the myotonia, everything is same. And the short stature, the changes in the skeleton, that's the distribution which helps you differentiate between the two. And the inheritance pattern, etc., is different. In congenital myotonia, usually the myotonia appears later. Does not become immediately after birth. Immediately after birth, they get the classical faces, open mouth, hypertonia. They later only they develop the myotonic phenomenon. But here from the early life, they have got myotonia. Okay, any questions? Other disease, congenital myotonia, the so-called Thompson disease, but they don't have the classical faces like this. They've got Herculean muscles will be hypertrophied and the proximal muscles are more affected. But they can also eyelid myotonia, but the faces, the short stature, this kind of a posturing, etc., may not be there in congenital myotonia. Okay, shall I go to the case?
Yes.
Okay. This is a long case. This is a story of a 65-year-old female. It's an old case of papillary carcinoma thyroid treated with iodine-131 ablation therapy 4 years back. She is presently admitted with history of numbness of both feet for the last 1 month. She is not a diabetic. In fact, that is only complaint by which she came. This on examination, cranials are all normal. The tone was normal. Power was also normal. Proximal muscles also normal power. There is no pseudoarthrosis. Mild suspicious incoordination of the left upper limb, not very definite. Very mild incoordination, not very convincing, but still can say suspicious. There is a mild postural tremor also. There is no loss of dexterity of the hands. Sorry. Coming to the lower limb examination, the tone was normal. Hip flexion normal. Foot flexion also normal. All muscles were normal power.
അതേപോലെ തള്ളവിരൽ പൊക്കി പിടിക്കുക.
THL was normal.
കീഴോട്ട് മടക്കി
Flexor lungs was normal.
അങ്ങനെ പിടിച്ചോ, അങ്ങനെ പിടിച്ചോ, കീഴോട്ട് മടക്കി പിടി, ഇത് പിടി, മതി, ഇനി വിട്ടാ.
The reflexes, upper limb reflexes normally elicited. Triceps also normal.
അത്ര ഇരിക്കട്ടെ, അങ്ങനെ ഇരിക്കട്ടെ.
Finger pressure is also elicited, just elicitable.
ബലം കൊടുക്കണ്ട, അങ്ങനെ ഇരിക്കട്ടെ.
Lower limb, left knee jack is slightly brisk compared to the right, or right leg height is low. Angle jack is just 1+ after reinforcement. There you can get there angle jack.
മുറുക്കി പിടിച്ചാമ്മ.
Get only after reinforcement. There you can get to see the muscle contracting. Okay, just elicitable, 1+. Plantar was indefinite. Chest sensation was normal all throughout. There is a pain level at that near about the ankle.
മുകളിൽ വേദന എടുക്കുന്നുണ്ട്.
He says it at that level it
ഇവിടെ
becomes
കുറവാണ്.
more.
വേദന കൂടിയാ പറയണം.
There it is more.
ഇതറിയാം ഒരു
Vibration is normal in the upper limb.
ഇപ്പൊ ഉണ്ടല്ലോ.
She said yes.
ഇപ്പൊ ഉണ്ടല്ലോ. ഇപ്പോഴേ.
Press in the ankle.
ഇപ്പോഴേ.
But in the toes she said it is less.
ഇല്ല.
You're not able to feel.
ഇല്ല.
So absent in the toes.
ഇപ്പോഴോ.
Joint sense is normal in the upper limb.
ഇപ്പോഴേ. ഇത്. ഇപ്പോഴേ. ഇപ്പോഴേ.
She said all correctly.
ഇപ്പോഴേ. 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 ഇപ്പോഴേ.
She said correctly, but made a mistake on the left too.
ഇപ്പോഴേ. ഇപ്പോഴേ.
Here she made a mistake.
ഇപ്പോഴോ. ഇപ്പോഴോ. ഇപ്പോഴോ.
He made a mistake.
പറഞ്ഞമ്മ.
But right side is normal, left side we made 2-3 mistakes.
ഇപ്പോഴോ.
Right side I checked again, it should not make any mistake on the right side. There is no limb attacks in the lower limb.
താഴെ മുട്ടണം.
Asian test was normal.
കട്ടിലെ മുട്ടിക്കണം. അതിന്റെ എടുത്ത് താഴോട്ട് കൊണ്ടുപോവാ. മതി. അതെ, വെടിന്റെ പുറത്തോട് വിളിച്ചുകൊണ്ട് പോവാ. കൊണ്ടുപോവാ. താഴെ മുട്ടിച്ചമ്മ. ഇനി എടുത്ത് മുകളിൽ വെക്ക്. മുകളിലോട്ട് കൊണ്ടുപോവാ.
Okay, look at the gait of the patient.
കാല് വേണം എനിക്ക് കാണാൻ.
Normal gait. But rhombox is positive in this patient. Rhombox is positive and tandem walking was defective. She is tend to fall backward on closing eye. This is tandem walking. This is also ataxial tandem walking. So physical findings and the gait abnormality seems out of proportion. So on examination, cranials were normal, motor system tone power normal in both upper and lower limb. Bilateral postal tremor of both hands, very mild. Detailed upper limbs all normal. Lower limb knee jacks, 2+ on the left side, right side 1+. Both angle jacks are just elicitable. Touch normal in both upper and lower limb. Pain, decreased pain below mid-shin bilaterally or below angle bilaterally. Vibration normal in the upper limb, decreased over both toes. JP is impaired over the right big toe, left big toe, normal on the right side. Stands normal. Rhombox test is positive, tandem walking defective. So, any questions regarding the findings? If you want clarification, I can clarify that.
Sir, is the patient having the residual tumor in the thyroid or it has been completely cured, sir?
No, it was completely cured as it is. No
Okay, sir.
symptom regarding that thing.
There is involvement of small fiber in the lower limb, sir, because of impaired pain sensation below the mid shin.
Very
Then
good.
there is a large fiber neuropathy or posterior columns. We have to further decide, sir. In addition,
Okay,
spinal tract is also involved in view of gross tandem gait impairments.
which is affected?
Spinocerebellar tracts or the cerebellum and its connections in view of the
Yeah.
gait and postural tremors in the upper limb.
Okay. So if you got a posterior column fiber sensations are affected, then it still can explain the ataxia.
But tandem gait is very much impaired, no, sir, for the
Yeah,
involvement.
yeah,
of the two.
you got a point, but no, it's very difficult to differentiate a sensory ataxia from a cerebellar ataxia. Impossible. It all depends upon the only two clues by which you can differentiate is presence of nystagmus and dysarthria. In the absence of which you can have severe incoordination, severe ataxia, even with neuropathy. For example, the term tropical ataxic neuropathy, about which I have studied many cases in Kottayam, the predominant manifestation is ataxia. The sensory loss is only very minimal. But ataxia is that's where the term came, tropical ataxic neuropathy. Similarly, in a subacute combination, ataxia is out of proportion, probably because of the posterior column also is affected. But so it does not mean that sensory ataxia did not have a severe ataxia. It can, but as you said correctly, the joint presence is only very minimal. The ataxia is grossly out of proportion. So that point we have to consider, because the way she made only 1 or 2 visual joint positions, and angle checks are elicitable, still she is ataxic. You have to consider that possibility. That is why I didn't look for the limb incoordination, heel shin test, but that was negative.
Sir, one thing, there is a disproportionate ataxia in relation to the findings.
Correct.
So if there is a gross amount of these types of ataxia, yes, the other explanation has been given by some of our colleagues, but I think we must have to also consider the involvement of the ganglions.
That's it. Right. You're perfectly right. So it may be involvement of the proprioceptive fibers in the peripheral nervous system, be it in the peripheral nerves, be it in the ganglion, be it in the root, or be it in the posterior column, wherever it is. So this kind of ataxia can occur wherever it is. Yeah, perfectly right.
Because
so the clue,
because she was a potential candidate of a CA carcinoma. So the ganglions in some of the cases are involved due to paraneoplastic diseases. And that will keep in our mind.
Yeah, sensory ganglion, one of the etiologies is paraneoplastic syndrome, as you said correctly said. So first we have to keep whether it's the problem is a problem of sensory ataxia, plus minus cerebellar ataxia, but no definitive cerebellar involvement, no nystagmus, no upper limb incoordination, lower limb incoordination is not so there. But some of the cerebellar involvement can be only gait ataxia. Like, for example, if it is affected the inferior vermis, like procranial lobe, they can only get ataxia without any limb ataxia. So that possibility is there, but in the presence of her symptoms and neuropathic symptoms, so we have to keep the neuropathy or the peripheral nervous system problem or a posterior column is more likely than a cerebellar lesion. That's it. But we cannot totally rule out the coexisting procranial lobe.
I got one doubt regarding her regarding her walking. That looks like slightly stamping.
Likely?
Stamping it.
Stamping gait, okay.
Posterior column.
Okay. On the right lower limb, I also have some suspicion about that, but I'm not very much convinced. But frankly speaking, I do not know. Real stamping is not there. But there may be a possibility. But here, sensory loss is very minimal in the only confined to the JP's and the big toe. That occasional mistake. Okay. So, what do you want me to do? What will you do in this situation to sort out the issue?
Nerve conduction.
I'll give you the nerve conduction. So it's a problem of sensory ataxia, very societal peripheral neuropathy. pre-posterior column affection. So NCS, this is NCS. So the motor amplitude normal, velocity normal, distal latency normal. Upper limb also normal. Now go to the sensory, upper limb sensations are all normal. The lower limb, or a mild decrease in the sensory, you can take it as with the normal limb. It's not very grossly abnormal to produce a ataxia like this. So 5.7, sense of the sural, 9.6, 8.5, sural is, supraperoneal is 5.7, sural is 8.5, 9.6. And FA latency is normal. So what do you want now? What will you be thinking now?
Sir,
Can
H
you
reflex.
Pardon?
H reflex was normal, sir.
H reflex was not done.
Yes, MRI.
Yeah, because the other possibility we consider posterior
MRI.
column, no? Because yes, could you embed posterior column sensation, but angle jacks were retained and ataxia is out of proportion. So posterior column. So MRI, which part of the MRI you want? Cervical, dorsal, lumbar,
Cervicodorsal.
cervical, dorsal. Okay. This is a cervical spine. T1. I'll show you T1. This is a T2. Sagittal. Okay, I'll go to the next one. This is again, I took a thin cut to find an abnormality in the cord, and this is abnormal. That is normal. Then took an axial cervical spine. Normal. This is again showing the sagittal cut. This is another thin cut was, this is taken again. This is a cervical cord axial cuts. So normal cervical cord. Then what else?
Dorsal and lumbar.
Okay, dorsal. Correct, because we have no evidence of an abnormality in the upper limb. Upper limb AP sensation was normal, there is no pseudothetosis. So the possibility of dorsal cord cannot be ruled out in terms of, not necessarily be cervical cord. So there's a dorsal spine. That was normal. I'll show some cut of the dorsal spine. Sorry. The upper cut I did not take. This is the T1, 11. This is the D2. What else you need? Lumbar, no? So it may be the lumbar radiculopathy then responsible for that. So lumbar spine is also done. This is a lumbar spine. So I'll show you each cut. This is D2 L1 level, L1 on the right side. This is L1, L1 L2, L2, L2 3, L3, L3 L4, L4, L4 5, L5 S1, S1. So lumbar, axial, and this thing normal.
SSAP, sir, to rule out roots versus tracks.
Okay, very good. So MRI brain. That's also done. The screening was done. That is normal. So my question is, what is your diagnosis now? Is it vitamin B12 deficiency then, which may be normal in this patient? So yeah, we did a homocysteine, that is also normal. Then what is the diagnosis now?
Sir, we have to image the nerve roots also to look for CIS.
Very perfect. Perfect. Okay. Now the thought came to me whether he is functional or not, because ataxia is out of proportion, angle jacks are normal. See, when a ganglionopathy, you suspect that thing. The only thing left behind is that a lesion confined to the roots, as you said. So CSF was done, which is normal. So I re-examined the patient to find out whether it's really genuine or not. Because no objective findings, other than the ataxia. So examined again, But the findings remain the
പൊക്കി
same.
പിടിച്ചോ പിടിച്ചോ
Power was
കീഴോട്ട് മടക്കിക്കേ മടക്കിക്കേ ഇത് മടക്കിക്കേ വിട്ടോ
very well elicited risk needed. Analgesics also elicitable.
Okay, ഇനി വിട്.
The sensory findings I will skip in the interest of time. That's also the same as before. So there is consistent finding. That means that makes function is unusual. There is no variability, inconsistency in the findings. So power normal is findings. So this is, as you correctly said, other test is SSCP. SSCP shows absent potentials from the lower limb. So what do you want now?
MRI of nerve roots.
With contrast. Okay. So contrast MRI, the lumbar spine and plexus, both is required. So look at the exterior image. This is exterior image. That's the root ganglion is thickened, and the nerve is also, the root is also thickened. I'll show you static Philip state. Again, you can find out the thickening of the nerve roots and the ganglion. Left more than the right side. This again, you can find that here the right is more enlarged than compared to the left side. This is the control patient. We are not used to this thickening of the nerves, real or not. So we took a control patient. We have got another patient with the same study which I have done. This is the control patient. You can see the size of the nerve. This is the normal patient.
Hello, what is it?
This is the control patient. This is the patient and the control. That is the one on the right side and left on the left side. Like did another again. It did a axial T2 with thin guts. See what is, you can observe here some other interesting finding. See the dorsal root and the ventral root. See, this is the dorsal root. The dorsal root is thick compared to the ventral root. See the anterior, this see like posterior and anterior root. That is more thickened compared to the anterior roots. See the dorsal root and the anterior root. So it is enlarged. Then it is another finding, the sagittal gut, some nodular thickening on the nerve root there. But only one place I could see that. Then the contrast was done. This is the contrast. You can see the enhancement of the contrast ganglion and the plexus. Bilaterally, more on one side. This is the asymmetrical enhancement of the ganglia. This is sagittal cut. Again, you can see the enhancement in the nerve roots. I will show a little lower down. See, that's the nerve root ganglion and the nerve roots. See the difference between the two. I'll show the static film paper. They are all the enlarged nerve roots. So it shows enhancement of the ganglion bilaterally. You can see it's slightly asymmetrical, more prominent on the right side. This again, you can make the difference between the right and the left. It is symmetrically, there will be doubtful whether it is normally variation, but asymmetry is there. That tells you that it's not unlikely to be, a normal variation. So what is your diagnosis now, as you correctly said? CASP.
Right.
So what? Yeah. So what is the investigation you do? Like to do?
Paraneoplastic panel.
Yeah, paraneoplastic. So did a CT chest and CT abdomen. Before that, angiogram scientist done. To rule out Sjogren's syndrome, ANA profile was sent. That is normal. Used a neck was done because she had thyroidectomy earlier, but there is no lesions in the carcinoma thyroid. But when you took a CT chest, the breast showed a cystic lesion. So FNAC was done from the cystic lesion, but that turned out to be a benign cyst, not a malignant cyst. Ultrasound is confirmed again, well-defined a hyperechoic region. So did FNAC, that was normal. That is negative for malignancy. So CAS patient was given 5 IUMP for 5 days, probably mycophenolate. So on the 4th day, she started improving, little bit, not very dramatic improvement, very mild improvement. They subjectively she says better, probably because steroid effect. No gross improvement, mild improvement may be there. That's all. We are only following it. Just decided yesterday only after 5 MP. 5 doses of IUMP. So any questions?
If ganglion is involved, why the sural and that H reflex is not?
Okay, that is perfectly, that's a good question. See, this is one peculiarity which we very often see, even the classical CASP with no involvement of the ganglion in clinically, evidence of electrophysiological evidence of ganglion, you can find enhancement there. Because this was again, time and again shown by Dr. Professor Kadilkar. The whole plexus may be thickened in CASP, not only the roots, whole plexus. But the finding electrophysiologically that may be normal. Why this is so difficult to explain? Probably because that particular, even though that is affected, that is not severe enough to produce an abnormality in the electrophysiology. That's all what we can say.
Sir, in this case, would H reflex help us in diagnosis?
Yes,
Because
yeah. H reflex will definitely help. SSCP also help. But SSC, H reflex only we can assess only one route, that is S1 route.
S1.
Yeah, so same with the SSCP also, you can only do it from the tibial. You can also do it from the upper limb, that we can do.
sir, actually, sir, we had a similar case with medullary thyroid carcinoma presenting with ataxia. In the normal paraneoplastic panel, it came negative, but when we did the extended paraneoplastic panel, anti-SOX1 was positive, which you can get in paraneoplastic thyroid disorders.
Very good. So in fact, I wanted to set a parent profile because before I thought I will do a CT chest and abdomen that is easily can be done easily. And moreover, after finding that, what do you call, the FNAC came negative, I thought we'll give a trial of steroid and mycophenolate. It's not improving. My idea was to go for a PET CT now. Because she had history of malignancy earlier. So even though nothing is there now, she may have something underneath. So because since PET CT is costlier, I thought I will give a trial of treatment. And then if not responding, because if it's paraneoplasty, she's not going to respond. And the involvement is also more like favoring what you see in a classical CASP with thickening of the roots and multiple. So those things favor a paraneoplastic, CASP rather than paraneoplastic. But absolutely one cannot be said.
Sir, if the patient does not respond well to this IVMP and mycophenolate, should we go for rituximab and other therapies?
Absolutely. I'll tell you one more thing. The CASP person usually do not respond to mycophenolate and steroid. I had one patient who had a good response. 3 other patients who respond only to rituximab. They got mild improvement with steroid and mycophenolate, but not satisfactory. Once they changed over to rituximab, dramatic improvement. So CASP usually responds to rituximab rather than other things, but taking into consideration the side effect profile and all, first we'll try with this thing. Let us see if responding or not. Not responding, go for rituximab.
So one more question is that in some CIDPs also and other hereditary neuropathies like Dejerine-Sotas, we get this clumping and thickening of the nerve roots. So
Correct.
how do we differentiate from this MR neuronography, whether it is thickening or it is an enhancement? Do we need to look at specific films?
Yeah, some of them have thickening, some of enhancement need not be there all the time. Some of the CADP, they can have thickening of the nerve roots. Enhancement may or may not be there. Enhancement is not a must. Only thickening of the nerve roots will be there. But how to differentiate from the other condition, which condition you are referring to, CSP with versus Dejerin Sotas?
Dejerin Sotas, yeah.
Dejerin Sotas as well as hypertrophic neuropathy. In CMT also they can have hypertrophic neuropathy. They got thickening of nerves throughout. Not only confined to the roots or ganglion, there will be peripheral nerves also are thickened.
Yes, sir.
Then basically Dejerin Sotas is a type of a HSMN type 3.
Yes, sir.
Okay, the lesson is that when you get grossly sensory conduction is abnormal, normal, and you find the other question is to answer is that why the patient is so much ataxic, out of proportion to sensory loss in this patient. This is
that
because
is the non ganglion lesions. The symptoms are much more than the signs. Yeah.
I know that is again because the loss of the large fibers in this patient. The large fibers carrying the posterior column. In those cases of ganglion neuronopathy, if you look, their sensations are also lost. Joint person is severely affected. Vibration will be severely affected, and they will be ataxic. But here, this is relatively normal. Not that totally normal, relatively normal. But ataxia is out of proportion. That is because the same explanation with the first doctor was referring to. This is peripheral also contains fibers destined to go to reach the spinocerebellar tract. See, if you look at the Miller-Fisher syndrome, you can have severe ataxia. What is the triad is ataxia, reflexion, ophthalmoplegia. But if you find JPS sensation post-colon normal in Miller-Fisher syndrome, but ataxia is out of proportion, gross ataxia. The reason is that there the involvement is the fibers coming from the spindles in the muscle spindles. The 1A fibers which go from the muscle spindle, they are affected, which are carried to the class column and then going to the spinocerebellar tract. If those fibers are selectively affected, as it occurs in some immune-mediated neuropathies like Miller-Fisher syndrome, ataxia will be out of proportion and less of other joint sensor posterior column vibrations impairment. Because peripheral nerve contains all these sensory fibers, those carrying the vibration, that's the touch fibers, those carrying the JPS sensation from the for conscious appreciation, and those carrying the proprioceptive for balance keeping, which are reaching class column and going to the spinocerebellar tract and reaching the cerebellum. The destination of those fibers are different from the destination of those fibers, proprioceptive fibers, which go to our parietal cortex. Those going to the thalamus and parietal cortex for a conscious appreciation of the joint position sense. Those going to the proprioceptive and going to the cerebellum for keeping the balance. So if those fibers are affected predominantly, you have ataxia out of proportion to the impairment of JPS sensation and vibration. That's the explanation which is offered in case of Miller-Fisher syndrome. Because the proprioceptive fibers coming from the muscle spindles are selectively more affected, which is destined to go to the cerebellum. That is why they get ataxia out of proportion. Am I clear to you?
Yes, sir.
Yeah. So something similarly is happening here.
So here the lesion is pre-ganglionic.
Pardon?
Here the lesion is pre-ganglionic.
Here, since the conduction is normal, lesion is pre-ganglionic. Sometimes you have to repeat the test again to find out ganglion is getting affected. That means SNAP will become progressively lower if ganglion is getting affected.
Since the protein is normal.
Since the protein is normal.
So in CISP versus ganglioneuropathy, in CISP where the SNAPs will never be affected, but in ganglioneuropathy it can be affected late.
Yeah, correct. To call ganglion neuronopathy, we should electrophysiologically SNAP should be absent. Then only we can know ganglion is affected. The SNAP is affected, the lesion is proximal to the ganglion. That is the central process fibers which go to the posterior column is affected. Because if ganglion is normal, the peripheral conduction is normal. SNAP will be normal.
Thank you. Thank you, sir.
Thank you.
Doubt.
Yeah, please, Bindu.
Then reflexes is not absent here, no?
Right, but that is also correct. Because here angle jacks are diminished, as you said, perfectly well elicitable. Okay, well elicitable. The point is that the same point which I have referred to earlier, see the fibers which are carrying the reflexes, the fibers which progressive include carrying the for your conscious appreciation, the fibers which carry to the class column are all different. So that is why some of the fibers can retain reflexes and then absent reflexes with sensory ataxia. Some have absent reflexes with sensory ataxia, so-called sensory ataxia, as in Miller-Fisher syndrome. That is in Miller-Fisher syndrome, those fibers coming the muscle spindles are also affected. That is why the reflexes are also absent. So absent reflexes, they got ataxia without sensory loss. Whereas here, if those fibers come, the muscle spindle is spared, only coming in the joint sense going to your cerebellum is affected. You can have ataxia without reflex loss, with retained joint muscle sense.
Okay, sir.
Or perception. You can perceive the joint sense, but those sense going to cerebellum is affected.
Oh,
That
got
is
it. Yes, sir.
That
Yes.
input is not reaching the cerebellum to maintain the balance.
Unconscious, like unconscious process.
Yeah, exact. Unconscious perception or perception. No, that is why I have brought this particular case. See, initially when the earthing came, normally I had a dot where I am reading with the functional in this patient. But since the patient is a VAP, I was literally very hesitant to try a functional techniques in this patient. So I just thought I will wait to do the SSEP also, because very odd, as you correctly said, the reflex are also retained, joint presence only very mild, then still patient is so much ataxic. So the functional element is strong in this patient, or suspicion is strong.
But
That is why it said traces. Pardon?
tendon reflex are diminished. They are diminished.
Yeah, but so many people even see, but still retain. No, that is the problem. Older people, they cannot diminish the angle jack. There is no definite evidence of a peripheral involvement in this patient.
Can you tell about that ganglionopathy and SNAP once again?
Yeah, I'll tell you. Please ask. See, to produce a SNAP potential, see, two things basic in electrophysiology. One is a demyelinating neuropathy, that is axonal neuropathy. In axonal neuropathy, the axon is arising from the cell body peripherally. In the case of motor fibers, it is in the anterior horn cell. For the sensory fibers, it is in the dorsal root ganglion. So, if any lesion occurring anywhere in the course of the nerve, from the cell body downwards, the axon dies off. So, if you got a lesion in the anterior horn cell, or in the anterior root, or in the peripheral nerve up in the motor fibers, your CMAP will be absent, will be gone. Because the fiber, after 7 to 10 days, the axon will die out and you will not get any potential or decreased CMAP potential. Same thing will also occur in the case of sensory neuron, but here the cell body is situated not in the cord, but in the ganglion. So just like anterior horn cell, but only thing is here is in the ganglion, not in the anterior horn cell. So what happens? Any lesion distal to the dorsal root ganglion, what we call, it's a bipolar neuron, central process and the peripheral process. It is a peripheral process, the dorsal root bipolar neuron is the one which is coming out through the peripheral nerve. So any lesion in the dorsal root ganglion and peripheral to that, anywhere you can have absent SNAP because that fiber axon get damaged. But the from the central process does not die off. So even the central process is the one which goes to the posterior root and reach the posterior column and go up to the tract nucleus gracilis and cuneatus. That will not die. That will also die in the case of ganglion is affected because that will produce hyperintensity in the posterior column if you do an imaging later on. But that will not come into the electrophysiological testing. If the dorsal root is affected, that it can die and produce posterior column also can produce changes, but that will not reflect in the electrophysiology. Because electrophysiologically, what we are checking only SNAP from stimulating the peripheral nerve. If that should be, if it is that is intact, snap will be normal. If that is affected, snap will be absent. So in the case of a radiculopathy, sensory radiculopathy, the central process is affected. Okay, the dorsal ganglion cell is intact. So the peripheral process is intact, you get a normal snap. In CASP, if the central process is affected, you can have changes in the posterior column later on. You can have hyperdensity. The posterior column also get atrophied. You can have abnormality in the SSCP. All can occur because of the deletion in the posterior column. Okay, you understood what I said? Am I clear to you?
Yes, sir. Yes, sir.
So that's the difference between SNAP and the CMAP.
It's
very useful.
The central pores are actually dendrites.
Central cause is the can't call dendrite, but it's a central and peripheral pores. That's what they're called. From cell body, bipolar neuron, one goes peripherally, one goes centrally. The central process is affected. The peripheral process will not die off. Only those going to the posterior column will die off. That is a SNAP result. Am I clear now? Is it clear?
Yes, sir.
So even if suppose you take a ganglion neuronopathy, you can have changes in both posterior column as well as peripheral. SNAP may be absent. If you take an MR, you may find hyperdensity in the posterior column. Means something like subacute combined degeneration. Because both central and peripheral processes die off. Because it is cell body is affected. But if the CASP posterior root alone is affected, the peripheral process will be retained. Only the central process will be affected, producing changes in the posterior column. Okay. Because the head is the central process. Okay. Shall I go to the next case?
Yes.
Okay. This is also a very interesting case. The story of a 65-year-old male, diabetic for the last 20 years. He gave history of ear pain and discharge from the right ear for the last 3 months, which is recurrent. Recurrent sense that he got treated, became moderate. Again, he had another otitis made in the same year. So 3 times he had discharge from the right ear. He noticed imbalance while walking with swaying to the right side for the last 2 weeks. That is the present complaint by which he has come to us. And dysphagia for 1 week. Facial deviation to the left with difficulty to close the right eye for the last 5 days. Slurring of speech for the last 5 days. So one more history again. Imbalance while walking, swaying to the right side for 2 weeks. Dysphagia and slurring of speech for 5 days. And facial deviation to the left with inability to close the right eye for 5 days. So this is the history. I think I will skip because Malayalam, the same thing. But the finding. There's no honors.
Light
No nystagmus.
Light no nystagmus. It's symmetry of the pupil.
The separation of doses, but
it's got
a right element facial. Masseter is normal. Sensations are normal bilaterally. It's same, he said. He said no difference. All difference is normal. But I said incomplete because of the facial palsy. It's got a right antennatic movement. Left part is going to the left side. Left cranial is normal. The vibration, he said, the air condition is better than the bone condition. Sorry. You can hear now. No. There the bone condition is better than the air condition. Yes, his bone condition is
എവിടെ
better.
ഏത് ചെവിയില്ല അച്ഛൻ കേട്ടത്? എവിടെ കേട്ടെ? എവിടെ കേൾക്കുന്നു പിച്ച? വലത് വശം ഇടത് വശം എവിടെ കേട്ടെ?
So he's pointing at the right side.
വിട്ടോ വിട്ടോ.
There is no incoordination of the fingers.
നീ മറ്റേ കേണ്ടി ഇതേ മൂക്ക് തൊട്ട് അച്ഛൻ്റെ മൂക്കത്തോട് അച്ഛൻ കിടന്നു. ഇത് മടക്കിക്കേ.
Lower limb power normal.
അത് മുന്നോട്ട്
There is no Hilshin incoordination in the lower limb.
കട്ടിൽ മുട്ടിക്ക് ഇവിടെ താഴെ മുട്ടണം. എന്നിട്ട് പിന്നെ താഴെ മുട്ടിച്ച് കറക്റ്റ് ഒന്നുകൂടെ ചെയ്ത വെച്ചാ ശരി. അത് മോളി വെച്ചിട്ട് താഴോട്ട് കൊണ്ടുപോവാ. മുട്ടിച്ച വെച്ചാ കാര്യം മുട്ടിച്ച് ഇനി ഒന്നുകൂടെ ചെയ്തേ കറക്റ്റ്.
The reflexes were normally elicited. Angiogenesis diminished, it's elicitable still,
ഡയബറ്റിക് ആണല്ലേ?
but diminished by both angles. Plantar was down to A.
ഇതൊക്കെ ഒരേപോലെ അറിയാമോ?
Sensations were normal.
എന്താ അറിയാമല്ലോ, വൈബ്രേഷൻ കുറവൊന്ന് ഇപ്പൊ ഉണ്ടോ? ഉണ്ടല്ലോ.
Then gait,
നേരെ നോക്കിക്കോ. ഞാൻ ഇപ്പൊ ഉണ്ട് വീണ പിടിക്കാൻ കേട്ടോ.
it tends to sway to the right side when you close the eye.
സ്പീഡ് നടത്തിട്ട്
Tandem walking, gait otherwise normal.
തിരിച്ചു നടന്നോ, കുഴപ്പമില്ല. തിരിഞ്ഞോ, ഒന്നും പറ്റില്ല. നടന്നോ, നിങ്ങളൊക്കെ നിൽക്കുക. നടന്നോ, സ്പീഡ് നടന്നു, ഫാസ്റ്റായിട്ട് നടന്നു. നടന്നൊരു പ്രശ്നം ഉണ്ടാവില്ല, മാറിക്കോളും. തിരിച്ചു നടന്നു, ഇനി തിരിച്ചു നടന്നു, തിരിച്ചു നടന്നു, തിരിച്ചു നടന്നു.
Gait others no ataxia while walking, but tandem walking was defective. He falls to either direction. On standing, he was falling to the right side. So, cranial nerves, no Horner syndrome. Exocular movements normal, no nystagmus. Apparent ptosis of the right eye. Fifth nerve, sensory motor normal, corneal reflex normal. Seventh nerve, right element facial palsy. And I did not show you a symbiote taste over the anterior one-third of the tongue. Eighth nerve, right conductive deafness. And right 10th nerve palsy. Motor system normal, cell system normal, detail all normal except for the action angle checks on both sides. Stands mild swaying to the right, more so on closing the eyes. Gait normal, tandem swaying to either side, slightly more to the right side. So you want to see I think it show the first examination findings. This one, this will come up again. No Horners, only the positive. Right element facial. Sensations were normal. Corneal reflex is normal. Right tentative palsy.
നാക്ക് നീട്ടിക്കാച്ചാ
Then the no, he said no. That means he's got a conductive deafness on the right side. So that's a problem. So where is the lesion in this patient?
Base of skull, sir.
Okay, you want any clarification? I can tell you. Base of skull. Okay, base of the skull means is it intracranial, extracranial, or the brainstem?
Sir, no, sir. It is probably recurrent CSOM causing skull base osteomyelitis with extension into the clivus, causing exudates in the base of the skull and multiple cranial nerve palsies.
Okay, but why should he produce ACE? But ataxia with tendency to fall to the right side.
Sir,
How do you explain?
probably due to vestibular involvement, which is coming.
But if it is a peripheral vestibulopathy, will it produce ataxia with falling to one side? Logically, you're right, but how can the vestibular affection is occurring in this patient? Ataxia is odd, otherwise everything is okay. Okay, the possibilities, one is it in the brainstem? Is it outside the brainstem in the posterior fossa, extramedullary intracranial, or is outside the cranium? Okay, so where is the localization? Should you prefer?
Intraaxial.
Pardon? Intraaxial, okay.
Because of the ataxia.
Ataxia is there. See, if it's only multiple cranial nerves are affected, its ataxia is very odd. In acute peripheral vestibulopathy, you can have transient imbalance, but it will not have persistent ataxia. Okay. Anything else? Any other possibility? Okay. We can explain the brainstem, we can explain the imbalance while walking, but we have to think of lesion extending with the pons to medulla. To think of brainstem, one possibility, odd point is there's got 10th nerve involvement and 7th nerve involvement. So without any other tract involvement in between, that seems little odd. So is it outside the brain in the posterior fossa, extramedullary, intracranial? Possible, but how to explain the imbalance while walking? Maybe due to compression of the brainstem. We can think that way. Is it outside the cranium? How to explain the imbalance while walking?
Headache.
Okay. Yeah, no headache.
Any headache?
Earache. Earache was there because of the otitis. Now it is not there. It was healed now. No, as I don't know the doctor who said, he said one possibility peripheral vestibulopathy. That in acute peripheral vestibulopathy you can have imbalance, which lasts for about 2 to 3 days. That is usual because and that imbalance usually occurs when the patient closes eye, fall to the right side, as you can see in this particular patient. But usually tandem walking will be ataxia to the same side, but area is falling to either side. That was little confusing in this patient. So whether it is because that is the only point to think of intracranial lesion, intramedullary lesion. Otherwise, everything can be explained by extramedullary lesion. So could it be that the imbalance is due to the unilateral acute vestibulopathy, second due to the recurrent otitis media? So that's also another possibility. Probably the vestibular damages occurred recently, not there before. That's also possible. Okay.
Bone conduction better than air conduction.
Yeah. Sensory nerve is not affected. Bone conduction is definitely better than the other thing. So what other tests we can do to find out whether it is a peripheral or central vestibular system is affected or not? We want to know whether its lesion is in the brainstem or outside the brainstem in the peripheral vestibular.
Head impulse test.
Yeah, good. Yeah, so you do a head thrust test. This is head thrust test. Now look, see, it's got a positive head thrust on turning to the right side. Taking to the left side, nothing is happening. See that? I will show the head thrust once again because it is so fast you may be able to. See that?
There is catch-up second.
Yeah, catch-up second on heading turning to the right side. That means the right vestibular nerve is affected. So there's unlikely, if it's a brainstem, it's unlikely to produce a head thrust test, except if it is affecting only that root and zone. That is possible. So there is one point favoring a peripheral. There is no skew deviation, no other findings in precise brainstem lesion. So as the doctor said, this is the first possible one possibility is very strongly this thing lesion is outside the brainstem. Now we know that lesion is likely to be outside the brainstem. How to explain the narrow palpebral fissure in this patient? It cannot be honest.
Facial palsy element.
But that little bit is Horner syndrome. You mean it's an apparent ptosis due to the facial palsy? Actually, it's a widened palpebral fissure. That is what you find is palpebral is wide because of the weakness of the orbicularis oculi in the produce widened palpebral fissure. So if you look at also the video once again, look very carefully the eye.
Corrected totally.
See, yes, ptosis is not there. Actually, it is going underneath the soft tissue and the supraorbital region. Can you see that?
Yes, sir.
Corrected totally. Highlight ptosis illa.
The eyelid has gone up, but see, I'll show the picture. Yeah.
Weakness of frontalis.
That is because of two things. One, it is the frontalis is out of proportionally weak. That is why the orbicularis. But again, usually facial palsy, this will not be seen because both the frontalis as well as orbicularis oculi are weak. So you will not find this kind of a phenomenon. But what you observe is actually the whole tissue is actually overhanging the eyelid. The soft tissues are overhanging. This is called blepharoptosis. So upper limb eyelid is bilid beneath the skin in the supraorbital region. This is called blepharoptosis. It's a drooping of the upper eyelid where the eyebrow is ptotic. Juxtabrow skin, lid fat, together with eyelid skin, hangs over the margin and may cause an illusion of ptosis when the eyelid occupies a normal position. I think you do understand. If the tissue here, look at the tissue here. Here it is overhanging the eyelid. That is a reason for that. Theoretically, it can occur with only isolated paralysis of the frontalis, yes. But the orbicularis also is weak, that usually is not, because it's contracting, that's why that usually will not get that.
No, normal people also it can occur.
Any old people you can have. In old people, that tissue can be lax. They can overhang you must have seen that, old people with it's hanging over the eyelid and can split blepharoptosis. It's a DD of blepharoptosis.
But
Yeah,
this
please.
is in only one eye. One eye.
Yeah, it can be one eye. It can be one eye. Bluetooth can be only one eye. Need not necessarily bilateral. It can be only one eye. No, other explanation is as Butch was telling, it's only predominant effort of the frontalis can produce this thing, where the upper eyebrow can come down. So now, is the lesion intracranial, extramedullary, or extracranial? What do you think? How to explain the recurrent otitis which has been there for 3 months? As he has already correctly said, does it give a clue?
Yes,
so
sir.
What condition?
Cholesteatoma.
Cholesterol.
No, not cholesteatoma.
Malignant.
Okay, osteomyelitis patient, do you think it will be like this, sitting very comfortably without, it will be very sick and all, no? Unless it's a chronic osteomyelitis. Yeah, chronic osteomyelitis like fungal and all. It's only 1 or 2 weeks duration. Okay, you want MRI. Okay, this is MRI. T2. It's got hydrocephalus. This is a T1. This is a diffusion sequence. SWI. This is the flare. Okay, MRI brain normal. What do you want now?
Sir, contrast.
Contrast. Okay, this is the contrast. Okay, what do you want now?
HRCT temporal bone.
Correct. So infratemporal region is the one we are interested. See, whenever get as the first doctor was telling, see if you get recurrent otitis media in an old age group, that means there is something obstructing the eustachian tube. That is the condition is nasopharyngeal carcinoma. That starts in the fossa of Rosenmuller. That is where the eustachian tube starts in the nasopharynx. That is original nasopharyngeal carcinoma. So these people come to you with the recurrent otitis as the first symptom. Those who have studied in Cotton Medical, I have taught this point many times. And if you get that kidney and they may come to you one claim now, you take a nasopharyngeal biopsy, maybe normal. Repeat after 1 month, normal. Third biopsy may pick up the nasopharyngeal malignancy. So this is one very tricky area where the ENT people take one bit and say it's normal. You have to pursue with him. I have seen biopsy become positive on the third attempt. But this is very strong possibility. Some otitis media developing cranial involvement. The lesion is outside the cranium, not inside the cranium. In the extracranial location, the base of the skull, so-called collet Sicard and Vernon, whatever it is, outside the cranium. Now let us see you want a cut outside the cranium. This is the base of the skull. So this is what is happening here now. You can clearly find out the enhancing lesion in the infratemporal region outside below the skull. This is an nasopharynx. You find the appendix lesion there. This is a normal anatomy and the other thing which we have shown correspondingly. This is the spinal cord and the odontoid and the body or the atlas. And this is the area which is affected. Just below the foramen serum, the infratemporal region, where the lateral pterygoid, everything is situated. Middle pterygoid, lateral pterygoid, little up. This again, another cut showing that this is a fossa Rosenmuller, wherever it starts. The eustachian tube starts. This is again from the picture from the net only on the right side. This is our patient. How this is the fossa Rosenmuller here, and it starts and spreading at the base of the skull. This is the clivus. This is showing the normal anatomy. This is the clivus that is infiltrated, that will become hyperintense here on this side. This is the joint here, and this is the middle pterygoid, lateral pterygoid. And look at the coronal cut. There's a nasopharynx, there's a bulge in the nasopharynx here. We'll show another cut. So that be only one picture. So, lesion encroaching at the base of the skull, possibilities and nasopharyngeal carcinoma, or infected cause like chronic infection like fungal granuloma tuberculosis lesion. That possibility can be ruled out. But the point is that the patient coming with recurrent otitis as the first symptom, make you suspect that this is likely to be nasopharyngeal malignancy. Because that is from there it starts.
So then why the ataxia?
Ataxia to acute vestibulopathie, as I was telling, because that's the only way to explain. That's why I did a thrust test and down. The lesion is due to the vestibular nerve itself. Vestibular involvement can produce ataxia in the initial few days. Here also, they will only tend to fall to one side. Just like here also on closing, it falls to the one side, right side.
So there won't be any giddiness?
Pardon? No, that won't. That need not put. No, that may produce a giddiness. Usually produce acute vertigo, but that need not be there all the time. Because if it is a little more slowly progressive acute vestibular, so actually the vertigo is due to what? It is the imbalance between the two input from the vestibular nerve. When one suddenly cut off, then you get imbalance. Cut off, you get vertigo. There is a slow progression of the lesion. Vestibular damage will not produce vertigo. Just like you would think in terms of acoustic neuronoma, it will not produce any vertigo because lesion is progressive. Here, it is somewhere in between. The vertigo is not there, but he's telling it is imbalance only. But no nystagmus, nothing in this patient. This I have seen, acute vestibulopathy without nystagmus only producing tendency to fall to one side. acute vestibulopathy. I will show one case next week.
Sir, you have shown these cases at Kottayam Medical College. I still remember one or two cases coming with pain and
yeah, right.
conductive hearing loss and these things.
You remember that patient I did pursued with that. The ENT people deferred. They said, you will not do biopsy. That
Yes,
I had
sir.
to go and beg him to do the biopsy. Did a third time biopsy, it can be positive.
Can be positive, yes, sir.
I remember that.
Yes, sir.
So you have to pursue with that, but suspicion is very strong. Now, what Bindu's question is very, very valid. See, usually in acute vestibulopathy, you get vertigo. And you get vertigo, and then imbalance will be persisting. Imbalance may persist longer than the subsidence of vertigo. So they go hand in hand. But sometimes disparity will occur because in an acute vestibulopathy, without much vertigo, without much nystagmus, only imbalance will be there. Here, probably because the input for the vestibular spinal tract, because the vestibular, the input from the labyrinth has got 2-3 things. One for maintaining the eye position, that is why nystagmus is producing. The other input for your vestibular spinal reflexes. When those fibers are affected, you get the vestibular spinal reflex will be lost and the patient will be suing will be the maximum. If you give me just 1 minute, I can show that video just straight away. Just 1 minute. Not just take. Yeah, I will show that video. Can you see this video?
No, sir.
Can you see it? No, you can see. Okay. I will, I'll show immediately after that, I'll show the video after closing this thing. But I have to come out of this thing. That's the one. Can you see now?
Yes, sir.
Yes, sir.
Yeah. See this particular person. He has got, nystagmus. He has come with difficulty in walking. Closing eye, he falls to the right side. Sorry, left side. Walking is okay, but tandem walking, he may mild ataxia and his fall right side. That is a classic acute vestibulopathy. He has no complaints of any vertigo, no nystagmus, and I will show the same patient's this thing. This is a head thrust. He's got head thrust positive onto the left side. Okay, so that's all for today. Any questions?
Sir, can you please analyze the head thrust test of that particular patient in your case? What was the present case? The case which you showed, sir, for this.
Yeah. Here, what happened was that when you turn the head, I'll show that this once again. Just 1 minute. Can you see the video?
Yes, sir.
Okay. Now, if you see, I'm turning the head to the left side, nothing is happening now. Jerking to the right side, see the correct is again. Not there. Not there. Now, let's see. Now, you can see that. That means on jerking to the right side, you get a catch-up saccade. So if it's a positive head thrust, means the side in which we find abnormality, there will be catch-up saccade. See, because the right vestibular thing is so this is based upon the vestibular ocular reflex. Vestibular ocular reflex is reflex which maintain your eye position in relation to the head movement. Suppose if I'm looking at an object, when we turn the head to the right side, eyes will still look at the same object. Irrespective of head movement, eyes will be sticking onto that particular object which you perceive. That is a function of vestibular ocular reflex. That means to maintain the image on the fovea, irrespective of the motion of the object, irrespective of the motion of the head. So that is this reflex doing. So what happened normally when you're looking at an object and turn the head to the right side, my eyes will be looking still at the object. This is because the input from the, suppose I turn to the right side, the input from the labyrinth reaches the brainstem and get connected to the contralateral abducent nucleus. So the contralateral abducent nucleus is for the contralateral gaze. That means it contacts the contralateral rectus ultimately through the MLA ipsilateral medial rectus. So when I stimulate the right side, my eyes will go to the left side. That is the normal vestibular ocular reflex. When you look to the right side, eyes make an equal and opposite movement to the opposite side. Similarly, when turn to the head left side, eyes will move to the right side. This is because the input from the labyrinth goes to and connects with the contralateral abducent nucleus through the vestibular nucleus. So when the vestibular system is affected, what will happen? This VOR is not working. So when you turn the head, suppose I got right side is affected, turn to the head side, that labyrinth is not functioning. So what will happen? The eyes move along with the head to the direction in which the head is turned. And I have to make a corrective movement because I am looking at a target, looking at your face. So what happened? When I turn the head right, I in fact did not make an corrective movement, opposite movement. So it dragged along with my head to the right side. So now I have to make a corrective movement back to the seen target. So make a corrective saccade back. So what you are observing is the corrective saccade. So the direction in which you see the corrective saccade means that side the VOR is defective. That is why on turning the head to the left side here, nothing is happening. Eyes are still looking at your face. On turning to the right side, that VOR is not working. So the eyes drags along with the right side and you make a corrective saccade back to my nose. Now let's see the video once again. That's normal. You can maybe not look at the right spot. You make a corrective movement, the eyes coming back. See that? The eyes going to the right side and coming back. In fact, if you had a slow motion video, I have been able to do better. Now you can see that. Okay, you did see that. Yeah, did you see that?
Yeah, it's clear, sir.
Okay. Yeah, okay. So, did you understand the mechanism now? Okay, is it clear?
Yes, sir. Sir, in
Yeah.
central lesions, what will be the finding in this test, sir? In central medullary lesions, or
Yeah, you can have a thrust positivity if the root entry zone, if the vestibular lamp is entering the vestibular nucleus, if lesion is happening at that region, you can have positive head thrust even in the brainstem lesion. Otherwise, this will not be seen. The lesion is proximal distal to that in the vestibular nuclei or is connected to the cerebellum, you won't get a positive head thrust test.
okay, sir.
Because it is connected straight away to the abducent nucleus. The other connection is going somewhere else, to the vestibular, to the floccular lobe, going to the cortex and going to the thalamus and cortex and to the spinal cord for a vestibular spinal, maintaining the posture and all.
Thank you very much, sir.
Thank you. So, okay. So we'll close it for today. See you next week.
Thank you, sir. Good night, sir.
Thank you. Thank you. Good night. Thank you all.
Good night.
Good night.
Thank
Good
you,
night.
sir. Good night.
Thank you.
Good night, sir.
Good night.
Good night.
Good night.